Thank you, Maria. Thank you to the organizers, and of course, thank you to the audience for coming here. I have introduced in the title of my talk, as you can see, a question mark, because there will be some normal variants, but also there will be some cases, as Dr. Robin has showed, and Dr. Rossi also, that are not quite normal, just to pinpoint the difficulty of dealing with these cases. So, sorry. We'll see a variety of weird appearances, such as pseudolumps, lines, bands, hole, island, such a whole variety of weird appearances. And we have to evaluate these appearances based especially on location, especially on the bone of occurrence, and as well as the segment of this bone, because there are many or several normal variants that happen to occur in these certain parts of the skeleton. So if this weird appearance is seen in this segment, a particular segment of the bone, we are quite sure that we are dealing with a normal variant. Apart from the radiological point of view, we have to bear in mind the age of the patient, because certain appearances can be absolutely normal, for instance, in the neonatal age, but beyond that age will be certainly abnormal. Clinical history usually is minor trauma or local pain, and especially if we are not confident with the diagnosis and the patient is still available, it's very useful to pinpoint the precise painful area and see if it fits with the area of concern in the radiograph. So, plain films are the mainstay of diagnosis. There is usually no need for any other further imaging, and as in any other area of radiology, we have to think twice before calling normal or abnormal and correlate with the clinical history. Rarely, other imaging modalities are needed only just when there is reasonable doubt. Well, we start with the cases. This is one. Of course, this can't be a mass. This is the external appearance of the baby, absolutely healthy looking. What happened? The problem was a very, very poor positioning at the time of the radiograph, accounting for this huge pseudolump in the right thigh. So take care of your technicians, because sometimes they provide this kind of awful films. Somebody see something there? Well, there are some high-density, rounded, and elongated areas that project on the frontal view of the skull, somewhat at the outer parts, and quite symmetrical. Is it calcification, vascular calcification, or parenchymal calcification? Well, as Dr. Robin has showed before, also in the neck, there is this fancy hair or net of this child that was responsible for these high-density areas projecting over the skull. In the neonate, we are going to see several particularly specific appearances for this age. First of all, the medullary cavity is thinner than in the adult, and then it gives the whole skeleton a relative high density and relative bone sclerosis as the whole skeleton. Also in the neonate, it's not infrequent to see some non-interrupted symmetrical periosteal reaction. And this periosteal reaction may be seen up to 4 months of age. Of course, if beyond that age, perhaps we would deal with severe diseases. Again, in the neonate, there will be many times some small transverse metaphyseal bands, radiolucent metaphyseal bands, that, apart from the neonate period, are quite abnormal and usually are related to severe disease, such as in this case of leukemia. When the transverse metaphyseal bands are sclerotic, usually are due to growth arrest line because of some previous period of malnutrition or severe disease, and then there's recovering of this process, and again another process, and this gives the appearances of these multi-layered sclerotic transverse metaphyseal bands. Well, this is one of the more commonest normal variants around the knee. There is an ill-defined lytic area in the posterior medial aspect of the metaphysis of the femur. This is always in this location at the site of attachment of the medial gastrocnemius. And this is always related to a normal variant, which is called distal femoral cortical irregularity, also called desmoid, periosteal desmoid, or any other synonym, but is absolutely normal. It resolves with time with any problem. So it's quite normal, and in a few years it disappears. Well, do we have the same here, the same lesion or the same pseudo-lesion? Well, it's in the posterior medial aspect of the femoral metaphysis, but comparing with the previous case, which is this is far apart from the physis. It's not the same location. Apart from that, we have a patient with pain and fever and a small calcification in the soft tissues, which on ultrasound presented a collection of pus. So, of course, clinical symptoms and location were clearly different from the previous normal variant. All over the skeleton, one may see thinner areas of bone or special arrangement of the trabecula, which gives or may give some pseudocystic appearance. For instance, in the intercondylar area of the knee, it's very usual to have this appearance. But believe it or not, in this case, the clinician asked about this pseudocystic lesion. So it's not uncommon for people not accustomed to these pseudo-lesions to ask if there is any pathology or not. Of course, one of the most commonest locations for this arrangement of the trabecula is the calcaneum. Another case of this arrangement. Well, I present this case not because of this pseudocyst, calcaneal pseudocyst, but because of this funny spur, which is called a reversed calcaneal spur. It's not in the location of the plantar fascia, it's reversed, and it seems that it's not very uncommon, because in this series it was seen at this age in about 5% of the cases, so it's not uncommon. But it is reported to be asymptomatic, and this patient had heel pain. So we were somewhat worried about that, and then we found this patient amenable to ultrasound, to heel ultrasound, and then we performed the ultrasound and saw the spur, but a lytic lesion appeared just adjacent that was not seen in the plain film, and then a kind of edema at the posterior non-ossified cartilage. And then clinical laboratory tests were performed, and it was osteomyelitis. And the patient was put on antibiotic treatment, and this 1 month follow-up radiograph showed some partial response with this sclerotic area, but the reverse calcaneal spurs was almost unchanged. So it was a normal variant, but something coexistent with this normal variant. Well, at the level of the pelvis, this is also perhaps the most common normal variant, and this is the exuberant ischiopubic synchondrosis. Maybe unilateral, as in this case, maybe bilateral, but always is completely normal. It resolves with time. It may be a slight increased uptake on the bone scan, but it doesn't matter because it's more metabolic. It has a more metabolic rate than the normal areas, but it's absolutely of no concern. Again, another case of the same. Do you think? Yeah, in this case it's bilateral, so even more normal than the previous one. but the patient had pain on the right inguinal region. So we have to look further, avoid satisfaction of search. Don't think that this is the pathology, but the pathology was adjacent to these areas, and then it proved to be a eosinophilic granuloma. So when we see something, and this something is a very, very tiny part, there is much more bone to look at than this only tiny part that was consistent with normal variant. We have to look at the whole skeleton, and especially if there is symptoms that there was in this patient. Around the feet, there are a number of ossicles, not to be confused with fractures or calcification in the soft tissues, and this is one of the most common. It's a sesamoid bone, the os peroneum, which is along the tendon of the peroneus longus. Again, another ossicle. In this case, is an accessory navicular, which is attached at the posterior tendon insertion. Well, here another ossicle, another variant. Well, this is more tricky because this ossicle is called os subfibulare, so below the fibula, is markedly displaced. So this can't be a normal variant. And here we see that it's still attached to the anterior talofibular ligament, but it is an avulsion. It's an avulsion of the tip of the fibula, and we must be aware that most os subfibulare, most of them, are in fact avulsions. Many of these patients have problems of instability at the ankle, so usually it's not a normal variant. Well, these are two different patients. The one with the transverse line is, of course, a fracture, the so-called Jones fracture, but the other one is absolutely normal. It's the normal and fused apophysis of the fifth metatarsal, which with a radiolucency parallel to the long axis of the diaphysis. So it's completely normal, and in this case, it's a fracture, well-known fracture. But what happens when there is ossicle where there is no secondary ossification center? In this case, the intercondylar portion of the tibia is not an area of secondary ossification center. So if we see an ossicle separated from the rest of the tibia, it should be, always should be, an avulsion of the ACL. So there is no room for normal variant here. This 13-year-old female presented with painful left knee and unremarkable plain films. So we performed an MRI, and we saw this area of periphyseal edema, which is believed to be to present at earlier stages of physiological physical closure, and it may be symptomatic, may produce pain, but do not need any other further investigation, no need follow-up, because it resolves absolutely without any problem. This 11-year-old presented with lumbar pain, back pain, and we'll see several facts. Here we see areas of ring apophysis, but a smooth vertebral body adjacent to the rings at the lower dorsal spine. But look here, a closer look. Here is the ring, but in this case, the anterior inferior vertebral border is kind of irregular and sclerotic. So this is no longer normal. This is how it should be the disc, and the disc has been herniated, anterior inferior herniation, the so-called limbus vertebra, as it was demonstrated in the magnetic resonance, how the disc is dehydrated and has herniated through the anterior inferior part of the vertebral body. Look at the rest of the disc, normal appearance. So in this patient coexisted normal ring apophysis at the lower thoracic level, but abnormal limbus vertebra at the S1 anterior vertebral body. Well, there is plenty of areas for irregular mineralization all over the body, as it is disclosed in this diagram. We'll see some examples of several cases. This 11-year-old presented with after minor trauma, and we interpreted the radiograph as uneventful because this was a cortical defect, fibrous cortical defect, of no significance, and there is a fragmentation of the posterior lateral condyle. So we talked the clinician that no further investigation was necessary. But he was son of a BIP, and then he forced us to perform an MRI. We did it, and again, we demonstrated the fragmentation with the overlying cartilage perfectly normal. So it was consistent just with fragmentation, irregularity of the mineralization of this area. The question here would be osteochondritis dissecans or normal. This is the question. Osteochondritis dissecans occurs 85% of the cases in the medial condyle, and when it happens in the lateral condyle, it happens in the anterior part and at the inferior central part. Almost never, although never is very difficult to say always, but almost never happen at this area, at the posterior part. So this is not an area of osteochondritis dissecans. Again, 2 years later, the patient came back because he followed with some pain, some vague diffuse pain, and you can see the change, absolute smooth margin of both femoral condyles, and there is just a tiny line as a remnant of the fragmentation that was present 2 years ago. So this is absolutely normal, not to be confused with osteochondritis dissecans. There is some healing of the fibrous cortical defect, as it was expected in this 2-year follow-up. Well, other areas of irregularity, which are quite common, are the ischial tuberosities. Here we have an example of a child with pain at the right inguinal area. If the pain had it been in the left, we would have dealt with some problems in diagnosis, and perhaps further investigation would have been needed. But because this is kind of a little bit funny looking, but the pain was here, the child was left alone, and no further investigation was needed. So there are normal ischial irregularities. What about this case? Well, this is a little bit different because there is displacement. So there is no longer the outline of the bone is no longer preserved. There is a displacement. So this is an avulsion, and the follow-up, 4 months follow-up, showed some sclerosis and resolving some healing of this avulsion, ischial avulsion on the right. So sometimes there are clear signs of that to differentiate normal from abnormal, as in this case. Well, what about the anterior tibial tuberosity? Everybody is familiar with the diagnosis of Osgood-Schlatter. I think it's one of the diagnoses that everybody knows, not only in the field of pediatric radiology, but in any field of general radiologist. Well, Osgood-Schlatter, in fact, is not a radiological diagnosis, because there are many possibilities or irregularities at the anterior tibial tuberosity. If the patient has edema, has pain and inflammation over the area, this is an Osgood-Schlatter, whether or not we see something or not. Sometimes we perform MRI because of other reasons. For instance, in this case, the question was to rule out a rupture of the ACL. The clinician knew that the patient was an Osgood-Schlatter, and of course we can see all the constellation of signs, swollen patellar tendon, edema of the insertion and fragmentation of the tibial tuberosity, and adjacent tissues, also edematous adjacent tissues. So these are absolutely signs of Osgood-Schlatter, but it was absolutely clear from the clinical point of view. So this is not a radiological diagnosis. Well, another irregularity, this is 10-year-old, presented with this unfused area, which correspond to the anterior patella apophysis. And in a follow-up, 9-month follow-up, this has fused with the rest of the patella, and it was completely normal. But in the meantime, the patient was put on a cast in another hospital, and for 5 weeks. So the reason was this misleading aspect. They took it for a fracture, and the patient suffered the cast during 5 weeks. So it's important to be aware of these normal variants. This was a child that fell on the elbow, and we saw this funny-looking proximal radius, kind of step, but she had pain on the non-ossified tip of the olecranon, and pronosupination was okay. So this can't be a fracture with normal pronosupination, and it was just a normal variant called step at the proximal radius, so nothing to worry about. Always correlate with the clinical symptoms. In this case, there are very clear-cut abnormality. There's 2 areas of lytic lesions which are close to the midline. So these are not histiocytosis. These are clear normal variant, well, normal to a certain point, because these are tender parts which can be dangerous for the patient because there is no bone overlying these areas. But these are the so-called parietal foramina. They may be associated with some brain anomalies, but the percentage of these anomalies is very low. But regarding these areas, simply a normal, not that normal, but not consistent with any tumor or any histiocytosis. The sutures, and here we see another extra line, extra radiolucent line. What's that? This is a variant. It's a unilateral, horizontal, parietal suture, not to be taken for a fracture. This patient, the radiograph of this patient was for follow-up of this notorious callus, the clavicular callus, but the clinician asked about this radiolucent line. Of course, this is absolutely normal. This is the physis, which is not totally tangential to the X-ray beam, and we are seeing 2 lines instead of 1, and it's completely normal. This is not a fracture. Here we see a funny-looking aspect of the neck of these humerus. So this is kind of unusual, and we can see a line overlying this area. So if it's possible, we have to take two projections. And of course, it was a displaced Salter-Harris fracture. So this is a case provided to me by Dr. Gloria del Pozo. Thank you. Well, what do you think is normal or abnormal? We've seen some cases of normal variants, but in this case there is a displacement, clear displacement. So another avulsion of the anterior superior iliac spine in this case, where the sartorius and tensor fascia lata are inserted. So always we have to see if the outline of the bone is preserved or not. In this case, it's clearly displaced. We've seen at the beginning of the talk a case of periosteal reaction, very, very innocent, but in this case there is not a neonate, it's a grown-up child, and we see this non-interrupted periosteal reaction, but we see another constellation of findings. We see widening of the middle joint space, so this is not normal. Ultrasound demonstrated joint fluid in the coxofemoral joint, and the MRI was clearly pathologic, not only the periosteal reaction, but also the medulla, and was the case of leukemia. So to summarize, in the neonate, we have especially 3 appearances, very, very frequent, which are this periosteal reaction, which usually is symmetric and uninterrupted. We can see relative bone sclerosis because the medullary cavity is thinner than in the adult. And we can see also radiolucent bands, in the metaphyseal radiolucent bands. Beyond the neonatal age, this is my particular top 5. The exuberant ischiopubic synchondrosis, the areas of pseudocystic lesion, either in the knee or in the calcaneus, has more common in the calcaneus. This irregularity and fragmentation of several of the epiphyses, in this case the posterior lateral femoral condyle, not to be taken for osteochondritis dissecans. At the level of the knee, also the distal femoral cortical irregularity, always posteromedial and close to the physis. And the feet, the unfused apophysis of the 5th metatarsal. So the conclusions would be we have always to evaluate the location, which bone is involved, which segment of this bone is involved, because there are many normal variants that are very, very characteristic of these areas. The age, we've seen that it's important to differentiate, especially the neonate from all ages. We have to correlate the precise painful spot if the patient is available with a lesion or the pseudo-lesion, because sometimes there isn't any correlation, or many times when there are normal variants, there is no pain. And we have the book that Dr. Robin has commented on. And I think it's a good book, but we should not take it always at face value. We have to be careful. And, of course, avoid satisfaction of search. So not be happy with something that we consider normal, but look at the whole picture. And in case of that, recommend and discuss with the clinicians what to do next. Thank you very much for your attention.